up?
Go ahead and walk. And so we can see that Mary is avoiding putting full weight on the right side. And is that how you feel?
Yeah.
You feel like you're trying to unweight the right side?
Yeah, otherwise it kind of like comes almost over here if I were to walk more normal. And
Okay. And of course you use a cane,
Mm-hmm.
but you're not using it now. That's fine. So come on back and go ahead and sit on the table. And you came to see me, you drove up from Arizona.
Correct.
And you've had a recent diagnosis of Ehlers-Danlos syndrome, hypermobility syndrome.
Mm-hmm.
Okay? And which I agree with completely. I mean, your fingers I can hyperextend. You have hyperextension in your elbow. It's a no-brainer. Your knees hyperextend more so than the average person. Okay? So I'm certainly in agreement with that diagnosis. You've had a history of low back pain, SI pain, hip pain, longer than 10 years.
Mm-hmm.
Okay. And you did have a right hip scope for a labral tear, but it was very complex. You also had some cartilage damage, and that surgery took 3 hours, whereas he thought it would take 1 hour. You've since had some workups on both hips, and there's still some pathology in both hips. Okay? But you feel like the driver is your sacroiliac or your pelvis. And you do this maneuver that you describe that gives you some ease while you're doing the maneuver. Can you show us that maneuver and tell us what it accomplishes?
Grabbing the top of my bone on my right side, I push it forward like that, and it opens up my hip joints, and I feel like there's airflow and blood flow, and feels more normal. I wish that it could kind of go up more. I can't make that go up, but I can make it go forward, and that provides relief.
Yeah.
But it's
Very
quite
good.
a bit of torque to do that.
Okay, alrighty. Well, I agree with you that there's a movement dysfunction with your pelvis. And I'm going to show the spring test that I do. I did check your ankles and your knees briefly and your hips. I'm not blaming the hips as being symptom provoking. I could be wrong, but let me just say that by testing different hip motions, I wasn't able to provoke pain. Okay? Your pelvis has good lateral mobility going right to left, and you had good mobility going left to right. The pubic joint is symmetrical from the upper front, middle front, and lower front part, and on the very top, walking across it, it is symmetrical. And I did some very gentle spring testing on the pubic bones, and you have a little bit of give in that joint, which is normal. Okay? Now, I'm going to demonstrate a posterior rotation spring test on the left. And I can push the pelvis and get it to move to a stop point. That's called taking up the slack. And then I add an additional thrust, and I feel this spring mobility through the joint, and it bounces right back. That's normal. That's normal in your knee. I should take any joint and I can load it and spring it. Any joint, you should be able to take out the slack and then spring that joint and get a little bit of give and a little bit of recoil. And it gets very interesting when we come to the right side. Now, some people talk about pelvic alignment. Your pelvis looks perfectly aligned. Okay? So the anterior relationship of your ASISs and then superior, inferior looks very symmetrical. If there's a difference, it's too subtle for my eyes. But more important than how it looks is how does it move. On this right ilium, I cannot take up the slack. I'm putting 15 pounds of force. I'm doubling that and there's no give. It feels like I'm pushing against a brick wall. Okay? And let's show what we find with you on your stomach. Okay? So go ahead and roll over. I'll take this face piece out. Now all spring tests on the sacrum, which was inferior glide, forward bending, backward bending, midline spring, each 4 quadrant was sprung, and then on under each side I did a spring test for side bending, and all of those spring tests revealed that I could take up the slack to a stop point, and then I could impart spring, and that force would go through that joint, through the rest of your body. But it gets interesting when we come to the right ilium. We also had normal spring on the back of the ischium, which tests the pubic joint. We also had medial mobility on each sit bone and lateral mobility on each sit bone. When we come underneath the left sit bone, I can take up the slack and then I can spring and I see the force translate. I see your head bob up and down. When we come to the right side, there's no give. It feels like I'm pushing against a brick wall. There's no yield. I cannot take up the slack and I'm doubling that force and nothing is happening. Okay? The opposite of that test is an inferior glide, and I can see your heel bob up and down. And on this side, I cannot take up the slack. I'm doubling that force. I'm getting no inferior movement. Now, it is interesting to note that you do have the ability to take up the slack forward, and I can spring it forward. So we do have forward motion, forward rotation mobility. We just don't have backward, and we don't have superior, and we don't have inferior of the right hemipelvis. There's one more test that's very important. The question is, could this ilium be stuck upwards, called an upslip, in relationship to the sacrum? And if that's true, then motion might be lost in both directions. Or could it be stuck inferiorly, which is called a downslip ilium? And in that presentation, usually, you will always have blocked superior mobility. Sometimes it has a little inferior glide motion. Other times inferior motion is blocked. And that is an anatomical variation as far as I can tell. Different shape of the joint yields different movement characteristic. So the question we're asking is this an upslip of the ilium or a downslip per Hesch definition, per my definition? If we look at landmarks, I'm on the PSIS and the right one looks deeper. No, it's really subtle. I'm not going to say deeper. I'm going to retract that. It looks inferior on the right, and if I'm on the top of the shelf looks lower, so it's leaning towards it being a downslip. But a very important test is to test the tone of the ligament. The sacrotuberous ligament comes off the inferolateral angle of the sacrum down to the ischial tuberosity or sit bone, and you can twang it like a guitar string to isolate it. I'm on it, and now I'm indenting it. It has a normal give, and it's supposed to yield a little bit. It should feel like a 3/8 inch nylon rope that's kind of tight. Okay? On the right side, it feels like bone. I cannot indent it. This feels like bone, and there is no bone right here. This is ligament. So that tells me that this is pulled down, and that ligament is being stretched taut, and that's why there's no give. So based on the ligament palpation, coupled with the motion testing, I'm concluding that this is what we call a right downslip of the ilium. Okay? Your feedback tells me that you're aware of this pelvis being functioning differently than on the left side of your body. Mm-hmm. You're aware that if you push on it, it relieves pain. And if you could keep it that way in the manner in which you push, you feel like the hips would have less pain. And,
upward and forward, yeah.
Okay. So I'm going to treat this, and I'll go ahead and continue filming and show what the treatment technique is. Okay? So what I'm going to do is have you lie on your back. And scoot down so your feet are off the bed. Good. So the way that I'm going to grab that stool. What I need to do is determine which angle I can gain some vertical motion through that pelvis. Now you'll notice that on this leg, if I push straight up, there's not much motion through her pelvis. Okay? And if I pull the leg outward, there's not much superior motion. Okay? But if I cross it over, called adduction, now you'll notice that I can get movement through the pelvis, and I see her shoulder bob up and down. Okay, so that's the sweet angle that we're looking for, in which we can get some superior motion through the pelvis. So here's a straight angle, and there's no real movement there. And then I bring this leg inward, called adduction, and now we have upward motion. So all I'm going to do is put her foot up against my chest or my belly, and I have her hip adducted about 10 degrees, and I'm just going to push it up, and I'm going to lean on that for 5 minutes. And then after we do that, we'll come back and we'll refilm the motion testing, the ligament testing, and we'll see how she walks and see how she feels. I will also teach her how to treat it herself, and we'll film that also. So thanks very much.